So, accurately diagnosing sleep-related events, and in particular distinguishing nocturnal frontal lobe seizures from sleep disorders, such as parasomnias, can be challenging. So in this 135, I will consider important diagnostic points in the history and role of investigations. So unlike generalized and temporal lobe epilepsy, frontal lobe epilepsy can cause significant diagnostic confusion due to its seizures having a wide range of clinical features, from the very subtle to the bizarre and dramatic, which may seem atypical of epilepsy and often be mistaken for non-epileptic attack disorder. And also, frontal lobe seizures have a strong preponderance to occur during sleep. Those who have 90% of seizures during this time are said to have nocturnal frontal lobe epilepsy. Age of onset is variable, but these seizures usually occur during childhood and adolescence, but can be diagnosed up to those in their 50s. Up to 40% of patients have a family history. Movements are variable, as I mentioned, but stereotyped with explosive onset of semi-purposeful motor activity, commonly bimanual and bipedal movements such as cycling, kicking, running, or axial movements such as rocking, sitting, twisting. There can be prominent vocalization, which is commonly unintelligible screaming, occasionally repetitive words or obscenities. Sometimes there is also tonic posturing or clonic jerking. Awareness is often retained as the seizure wakes the patient, and they may recall an aura, which is often non-specific, but a number report a choking sensation. The events usually last seconds to 2 minutes. If longer, frontal lobe seizures are highly unlikely. There are 3 to 8 attacks typically occur per night, 20 to 40 episodes a month, and clustering over 1 to 2 nights is common. They can occur any time, but generally in non-REM N2 stage of sleep, particularly in the first 30 to 60 minutes of sleep onset or just before waking. Axial EEG is often normal or obscured by movements, and epileptic form changes are seen in less than 50% only, and in around 15% of patients. In around 50% of patients, neuroimaging can show cortical dysplasias, ischemic or gliotic lesions. So regarding parasomnias, the behaviors which occur exclusively during sleep, there are 3 types: non-REM disorder, REM disorder, and the overlap of the two. Non-REM disorders are the most prevalent and most likely to cause confusion with epilepsy. They're categorized into 3 subtypes: confusional arousals, sleepwalking, which also include other semi-purposeful movements such as moving objects, eating or drinking, and sleep terrors, which includes autonomic features such as tachycardia and fear. The patient usually has no recollection of events or occasionally has vague remembering, but irrespective of the subtype, they have the same underlying mechanism, which is incomplete or impaired arousal from deep non-REM sleep, resulting in overlapping of sleep and wake states. They usually begin in childhood, less than 10 years old, and often terminate in adolescence, though it persists in 1 to 4% of adults, and 60 to 90% have a family history. Events are brief, lasting seconds to 3 minutes, but can be more prolonged, sometimes up to 30 minutes. 1 to 2 attacks occur per night, and less than 1 to 4 episodes a month, and they occur during the first third of the night, usually within 1 to 2 hours of sleep onset, when slow wave sleep stage N3 is achieved. Poor sleep quality due to sleep deprivation or drugs that affect sleep, such as sedatives and anti-seizure medication, could be a trigger, along with febrile illnesses, alcohol, stress. EEG shows no epileptiform features, but sometimes slow waves. And the treatment here would be good sleep hygiene. Low-dose clonazepam can sometimes be considered, as well as antidepressants. And lastly, REM sleep disorder arises through failure of normal muscle atonia during REM and results in dream enactment. Most likely, this arises from damage to a small area ventral to the locus coeruleus, and it's frequently associated with neurodegenerative disorders, particularly Parkinson's disease and MSA, with the sleep disorder often occurring several years before the most features. Age of onset is in those over 50 and in predominantly males, where 80% of cases occur. And events can be complex with violent behavior, with screaming, punching, and kicking, which can often injure the patient's bed partner, though more subtle, brief, jerky movements are also common. But unlike non-REM disorder, walking is very uncommon, though patients may fall out of bed. Patients can usually be wakened from the events where they may recall vivid dreams, and there is very quick recovery to alertness. Events usually last less than a minute, and several events can recur a night and become more vigorous as the night proceeds. They usually occur in the second half of the night when the greater proportion of REM sleep occurs, and EEG, as expected, will be normal. And if drug treatment is to be considered, clonazepam, and potential additional melatonin is chosen. So in conclusion, a good, careful history should be sufficient to distinguish nocturnal frontal lobe epilepsy from parasomnias, along with other methods such as home video, clinical questionnaires, and when diagnostic uncertainty remains uncertain, EEG and neuroimaging, as well as, I always don't know how to pronounce, polysomnography, can be useful, though they have their limitations, along with a trial of anti-seizure medication in certain cases. Thank you.